Okay, it's just now 2 o'clock, and I know folks are still joining. This webinar kicked off for today. We have a lot to share on this call. Very excited about the interview that you'll hear, and so let's just jump right in. So welcome everyone. Thank you again so much for taking the time to join our Care Transitions Peer Learning Hour today. My name is Caroline Ryan, and I work for the Administration for Community Living. At ACL, I lead a team that is leveraging knowledge across ACL programs to provide care transitions technical assistance, really TA to states, to local organizations during COVID-19. We are providing both one-on-one technical assistance and also group learning activities, which this peer learning hour is one of those group learning activities that we have on a regular basis. So for those of you who may not be familiar with these learning hours, they focus on interviews with your peers.
But like she would be an awesome.
I think we have some background noise. There we go. Thank you. So, okay, so for those of you who may not be familiar with these learning hours, they really focus on interviews with your peers about transitions innovation during the pandemic. The goal is really to provide you with actionable information that you can then take back to your organization to help either launch or expand your transition work during the pandemic. These calls are recorded, and you can access the presentation materials through a web link that we are going to post in the chat. And speaking of the chat feature, we do like to encourage participants to use the chat to ask questions, share insights throughout the entirety of the call today. We're also going to use the chat to post links to resources that come up on the call, like the link to the presentation materials. Another collaborative tool that we use on these calls is called Mentee. We use it to provide real-time feedback from participants on the call, so you can get a sense of what your colleagues are experiencing with their transitions program sort of in real time. So we will have some Mentee polls during the interview, and I will help with some practice before I turn the call over to our next presenter. But first, we can go over the agenda for today. So I think we can go back a slide. There we go. So just a quick review of the agenda. After these opening remarks, we are briefly going to talk about the importance of care transitions during COVID-19. That will be followed by an interview with a team from Elder Services of the Merrimack Valley North Shore, and also a team from Greater Lynn Senior Services, who are going to talk about transitions innovations before and during the pandemic. We also set aside some time for Q&A to respond to your questions in the chat. So again, would encourage you, as we go through the interview, send questions in through the chat. If we go to the next slide. So before we get too far into the call, I wanted to describe what we mean when we talk about care transitions. Care transitions, or transitions of care, describe what occurs when an individual moves across healthcare providers, settings, and home as their needs may change due to chronic or acute illness. Now that's a very big, broad definition. So for our COVID-19 transitions work, we really focused on transitions to the community from hospitals, short-term skilled nursing facility stays, and longer-term nursing home residential stays. So I think, as many of you are very well aware, poor transitions can cause some people to fall through the cracks during and after discharge, which can have serious impacts on both health, quality, and also on cost. And so when we talk about coordinated care transitions, we're recognizing that people discharging from a hospital or a nursing facility may have both medical and non-medical support needs post-discharge. And many of you on the call, many folks in the aging and disability organizations have experienced supporting smooth transitions by connecting people to community services using a variety of different programs and funding sources. So I thought I might give you a couple of examples to help sort of provide some context about care transitions. So a couple of examples include person-centered planning and connection to home and community-based services during transitions from nursing facilities through the Money Follows the Person program, implementing evidence-based models to support hospital transitions through a CMS community-based care transitions program, and streamlining access to community services during transitions through Aging and Disability Resource Center No Wrong Door grants. So there's been a lot of activity historically in this space, and just hoping that this information and some of these examples provide some context about what we're going to talk about on this call today and in the context of COVID. So if we go to our next slide, before I turn the webinar over to our next presenter, I did want to thank participants on this call that responded to our transitions TA survey. Your feedback is essential for our TA planning. We want to make sure that the information and the webinars that we are providing are responsive to your TA needs during the pandemic. And so just briefly wanted to share 2 slides that give some insight into some of the TA feedback we received. The TA survey was sent out to everyone who is signed up to be notified about these peer hours. And we heard from 93 organizations across 35 states. And so this slide just shows the range of aging and disability organizations that responded to the survey. And you may notice that about more than half of the organizations that responded currently have a transition program. So on the next slide, we received a lot of feedback about top barriers and TA topics requested. And so our next slide, there we go, includes both barriers and the TA topics. So the top 4 reported for barriers were around funding, healthcare partnerships, staffing, and then some waitlist capacity resource issues. In terms of TA topics that folks were requesting more information on, we heard feedback about program structure and setup, funding, partnerships, and building relationships. So really our next step with this information is to use it to design our upcoming peer learning hours and our informational materials. So if you're reviewing this list and you notice that your organization has had some success addressing these barriers during COVID or these TA topics, and you'd like to share your experience on a peer learning call, please feel free to reach out to us. We do have an email address that we're going to put into the chat box, the ACL Care Transitions email address, and feel free to reach out to us and perhaps we can highlight your work on a future peer call. So now before I turn this over to Tim, we're going to practice with Mentee, just so you're ready for the polls when they come up during the interview part of the presentation. So let's just check in. There we go. And I want to ask Jessica and our colleagues at Lewin if you have some instructions around connecting to the Mentimeter that you'd want to share.
Hi, Caroline. Yes, so this is Helen Dawson with the Lewin Group. And I'm going to go ahead and share my screen that has the Mentee on it. And so you guys can see here that the instructions are in a browser window. You can use really anything. You can do it on your phone or on your computer. If you go to www.mentee.com and submit the code 800-96169, you'll come to this polling platform. And so the first question will be up when you come to that website. And it's really just an initial question of asking, what is the name of your organization? So wonderful. I see we've got somebody that's on it. They must have been on this before. Freedmen's Health. That's wonderful. So we'll just give others a bit of time to join.
And so this will give you some.
Look.
Sorry,
go right ahead, Caroline.
Just wanted to add that this gives you some experience that with Mentee, there may be times where there is some text options where you would type in something versus selecting some options from a menu, which I think will be our next question. Go ahead, Helen.
Yep, absolutely. So we can just see through here. I'm seeing we're all over. We've got great representation. We've got Iowa, Georgia, Maryland, seeing even more, Oregon, Ohio. So this is wonderful. We've got great representation today. Will go ahead and put the link Jessica has just put into the chat, and the code she has also put in there as well.
And if you are unable to access Mentee, please feel free to put the information into the chat box so that we can also recognize you there, which I think we've already got some folks doing. You've been on these calls before.
Wonderful. So looks like our responses are slowing down a little bit. So I can, in just a couple more seconds, move us on to the next question. I want to make sure to give everybody enough time. All right, so if we move to the next question, this is going to be a multiple choice option. So which of the following options best describes the type of organization that you represent? And if it's a little small on the screen, I can just show you it's SUA, State Unit on Aging, an Area Agency on Aging, Aging and Disability Resource Center, Center for Independent Living, a tribal organization, a network lead entity, a community-based organization, or other. So it looks like we have a great number of SILs, AAAs, state units on aging joining us today. So this is wonderful.
Okay, it looks like our responses may be slowing down here. Thank you so much for folks who practiced here on Menti and for sharing information in the chat. Hopefully it gives you a sense of who's on the line, and then also using this as we go through the interview. So now I would like to turn the call over to Tim McNeil. He's going to provide a brief overview about the importance of care transitions during COVID-19, and he's also going to facilitate the interview. Tim, the floor is yours.
Great, thank you so much. It's a pleasure to be on the presentation today. And today we're going to feature a market where there's always been a hotbed of innovation in Massachusetts. And as one of the medical directors there, Dr. Rob Schreiber used to say, Massachusetts is land of ACOs, which means that there's lots of providers entering into risk-based contracts. And so today we get to see how that has rolled down to community-based organizations that are also engaged with those hospitals that are in risk-based contracts and then themselves are entering into risk-based contracts. Next slide. So today we're joined by leaders from Elder Services of the Merrimack Valley North Shore and Greater Lynn Senior Services. Next slide. So our panelist today is Joan Hayden-Roy, which is the Chief Executive Officer of Elder Service of the Merrimack Valley North Shore, and Christine Tardif, which is the Chief Operating Officer. And from Greater Lynn Senior Services, we are joined by Valerie Parker Callahan, which is the Director of Planning and Development and the Director of Silver Otter Strategies, and Stephen Gallant, which is the Director of Population Health Initiatives. And they, in their own regions, are managing and operating a very innovative program model that is called the Community Partner Program, which we will learn a lot about today. Next slide. So we're going to roll into our questions for our panelists. So first, we want to find out if we can learn a little bit about the Community Partners Program and the role that these two innovative community-based organizations play in operating that. So MassHealth, which is the Massachusetts Medicaid division, created the Community Partner Program to provide care management and coordination for Medicaid beneficiaries with complex behavioral and long-term service support needs. So we can first hear from the Elder Service of the Merrimack Valley North Shore team. Can you describe an overview of your program and how you decided to implement the Community Partner Program in your market?
Sure. Hi, this is Christine. Thank you, Tim, and thank you everyone for having us on today. So as Tim described, we are what we call a community partner, and we partner with 11 ACO, MCO partners in this model. And there are two different kinds of community partner. There's a behavioral health community partner, and there's a long-term services and supports community partner. And Merrimack Valley Community Partner, which is what we call ourselves, is a long-term services and support community partner. In our model, we partner with a local ILC that's also part of our ADRC, and that's Northeast Independent Living. And in this partnership, we have sort of a 50-50 relationship where we share the responsibility across the board. And as part of this model, we have care navigators that are in the field and working with members that get referred to us from the ACOs. And part of our main role in this program as a community partner is really to facilitate care coordination. So the goal of this program, as Tim mentioned, is really the integration of behavioral health, medical components, and then the long-term service and support needs. And we are definitely a relevant part of the care team. And serving in the LTSS capacity, we work with our ACO on shared members. And just to give you a sense, we have about close to 700 members enrolled in our program at this time. So our role is really that outreach, that care coordination piece. There is an element of care transitions that we are responsible for in this program as well. So that's sort of just the broader model that we use in this program.
Move over to the GLIS team, I do want to highlight that under the community partner model, you receive funding for this work that you are contracted with Mass Health that provides a funding source for you to implement this model. Is that correct?
Yes, we do. So the way that the payment stream flows is that we get our payment directly from Mass Health. And that payment under our contract, we have very specific, there's a couple of different streams. We have very specific qualifying activities that we are able to bill for and get paid for. We also, on the risk piece of the contract, we have a withhold that's tied directly to quality metrics that has been an integrated piece of this program. So we've gone from a reporting component to a pay for reporting component to now entering into a pay for performance component of the program. So right now we're still in the pay for reporting phase. So there's a quality withhold that's held. And then once we have our audit from Mass Health, those quality funds are released based on the scores from our audit.
Chris, I don't know if we needed to add in the beginning that the ages that this program covers from ages 3 and up, just to make sure that the audience knows that it's not just seniors.
So that's an excellent point, that this covers a large, diverse age group. And it's your task as the community partner to really look at all available resources to meet the needs of the population, where you're blending and braiding and combining resources to meet the overall need. And you all, as well as our partners at GLIS, have a long history of working with hospitals in that nature, where you're working to combine resources to meet the need. Is that correct?
Yes, so we, as Joan said, we serve a very diverse population under this program, and we actually have a very skilled staff that has the experience to deal with that. I would say about 20% of our population within our members are under 18 years old. So that's a very different approach that we've taken to care coordination. And we've built a very robust resource center to help our navigators work with families. A lot of what we see in this program is not only working with the member, but also working with the families that make up that nucleus of the member. So it's interesting how much our role has expanded with our experience in this program.
It is very interesting, where generally area agencies on aging don't generally serve a younger population, but the opportunity presented itself, and it sounds like you all rose to the occasion, modified your approach so you could meet the needs of everyone.
Absolutely.
Excellent.
Now, on that point, Tim, I just want to comment on that point. I think one of the interesting things about this program is you go into a home for a referral for one person, but you could see 3 other members in the family that ultimately you help make a referral for, that the program also works.
Wow. So the program allows you to look at the needs of the entire family and then see how you can address, really to heal the home. That is
So in many cases, you really can't work with a specific member unless you are working with the family dynamics. So it really does require that you have much more of a broader view, and that you're able to understand how these dynamics are interacting and creating the health outcomes of the member that you've been assigned.
So for our audience, the two last persons that just spoke, that was Valerie Parker Callahan and Stephen Gallant from Greater Lynn Senior Services. So there's actually two different teams in Massachusetts. And so I want to just roll right into the GLIS team to give us a description of your program and how your program's operating.
So I need to apologize. I'm originally from the Bronx and Steve is from Gloucester, and we just barge right in. So I apologize.
Oh, you're
but thank you so much for inviting us. We're very pleased to be here, and especially pleased to be here with our colleagues from Merrimack Valley. We're also a part, as you mentioned, of the Mass Health Demonstration Program. There are 9 LTSS community partnerships. Elder Services of Merrimack Valley is part of one, and GLIS is part of another. I think what makes both of us a little unique in terms of the very small universe of these LTSS partnerships is that we, as AAAs, really are leading the management of this program, while there are other AAAs involved in the other 7 LTSS partnerships across the state. They don't have quite the same role in terms of overseeing the day-to-day, making sure that the analytics are on track, making sure that all the administrative capacities are on track. So this is a bit of a broader role. We also are partnered with actually 12 ACOs, MCOs. We are, as are the others, working to provide the supports for folks between the ages of 3 and 64. And about 40% of our maybe 650 to 700 enrollees at any given moment are under the age of 19. So we have even a greater, I think, proportion of pediatric members. Our partnership is one with Northeast ARC, as well as Bridgewell, and Bridgewell is an entity that covers a large region, focusing on providing supports for people living with disabilities, as well as with substance use disorders. In our case, all of the LTSS coordinators, we call our folks coordinators, who are on the ground delivering the services, are actually hired and supervised by Greater Lynn Senior Services. We rely on our partners to provide us with a very strong level of training, particularly around issues involving pediatric concerns, because as you can imagine, as a AAA, that was not our main focus initially, but we have learned a great deal. And we actually insist on a lot of cross-training for our coordinators so that everyone is able to work with a lot of the family issues, and also can recognize many of the symptomologies that are critical in order for us to provide the right kinds of coordination. Our focus is largely on helping consumers address and manage the social determinants of health, or health-related social needs, which I guess they're called more on the ACO side. And we're looking to see which of those are contributing probably to the poorer health outcomes. Usually it is something connected with housing or nutrition or mobility, or improving the good fit between a person's environment, both in terms of his or her routines and the infrastructure of the environment, and their capacities, abilities, and interests in creating sort of their capacity to navigate through that. We are very much focused on person-centered planning. We're very serious about that. We want to make sure that our care plans make sense to the consumers, that they're motivated and incentivized to follow through on meeting their goals. And that really is our main focus, is helping to support folks to go through this plan and meet their social determinants of health challenge. And we do so within a program, and I think Christine and Joan and Steve will agree with me, that is really complex in terms of how one has a qualifying activity and when one has a qualifying activity and what has to happen where, and how we need to interact with our ACO partners and so forth. So I'll stop there because I think I've probably been babbling on a bit too much. But it is certainly a program that you can talk about for many hours on end.
Great. You touched on some key touch points there, things such as social determinants of health, how that gets incorporated in. I think you also mentioned you have relationships with 11 different ACOs, sounds like multiple hospitals.
We have 12 ACOs,
Great.
ACO MCOs, yeah.
Excellent, excellent. And that incorporates to how many hospitals?
Oh my goodness, I don't know, a lot of them. There's a lot of,
Excellent.
and we are, I guess, something like 68 different communities in Massachusetts.
You both programs spoke to how aging is working with the disability community to serve the needs of the broader population. But it sounds like you both approach your integration with Centers for Independent Living or the disability community broadly in a little different manner. So Christine, can you tell us, you mentioned the partnership between the Center for Independent Living?
Sure. Yeah, I can talk about that, Tim. So yes, we do have a partnership. We are the lead, and we have an affiliated partner, as I mentioned, NILP. And the relationship for the most part is 50-50. So we have some of our staff is employed with NILP and some of our staff is employed with ESMV. But essentially we make up an entity called the Merrimack Valley Community Partner. So the entity is really who works with the ACO and MCO partners. And we present as one, so again, it's a 50-50 partnership, and the referrals come in through a central point so that the transactions are seamless with the partners that we have in the community. And that's been one of our biggest successes, I will say, is having that point of contact that we utilize for all of our partners, because a lot of the partners that we work with have slight differences in their documented processes and the way that they work. Although the program is extremely regulated, there are differences in some of the processes, which makes the administrative burden on this program a little bit more than we'd like it to be. But having that one point of contact and that central point has been essential for us. So when those referrals come in, when that information needs to be shared, it's really centralized. So they view us really as one entity. And I think that's important to highlight because they're really getting, I think, we've done, I think one of the biggest challenges with the rollout of this program is really being able to articulate our value proposition to our partners. When we first started this program, a big part of the work we had to do as an LTSS CP was the education, particularly around the physician partnerships and the practices. So we were really out there educating our hospital systems, educating the providers, and really understanding what we did as a community-based organization. And I think the blend of having the expertise from the disability community and also having the expertise, a very broad expertise, I would say, from the community-based organization as we are, has been a really nice blend and has been able to service our members very well. Again, we're serving a very broad range from ages 3 to 64. These members are extremely complex.
I'll go out of it and then come back into it, and then it'll let me print a couple pages. I wonder if the file.
Sorry, that's my train of thought. The members that we serve are extremely complex. They have very, they're very heavily oriented into the behavioral health component. They're very heavily oriented in the medical components of their care. So with the LTSS needs, we are seeing a blend of all three of those worlds. And I think having this unique relationship and this partnership with our ILC has been really robust and has, I really do believe, has opened the hospital systems and the providers' eyes a little bit as to the breadth of the services that we're able to provide. I also think what's impressive and what they've learned over time is that because we are deep-seated in our communities we serve, we have very, very close connections to community partners that, you know, when we talk about, is it better to build or buy? I think what the hospital systems are realizing is that, yes, on paper, potentially they may be able to mirror or think they can mirror some of the work that we do, but they don't have the depth in the communities that we serve. And I think that's really a big and something that our partners are really starting to better understand as we work with them more closely.
Excellent input. Now it's time for audience input. So we're going to go to our next Menti poll question. If we can pull up the Menti poll question.
Yeah, so if you go back to the browser in which you had it up before, we are just moving through the questions that we had. So this one is whether or does your ADRC fully integrate services of the AAA or the SIL through a single referral mechanism to meet the needs of both populations? So I'm seeing some answers coming through. Now, if you closed out of your browser and need to come back to it, it's the same instructions and you'll get put right back into this part of the presentation or the poll. So it's the www.menti.com. And then the code is the same, the 80096169.
So it's not often that we hear this great collaboration that we're seeing with both GLIS and Elder Service of the Merrimack Valley North Shore, where they're integrating both Area Agency on Aging expertise and expertise from the disability community to meet the needs of the broader population. So we want to learn how many of these types of great innovative relationships are occurring in the field. So your input is very valuable. So it looks like
wonderful.
Slow down.
So I can take us to the next question. So has your organization seen an increase in referral volume to address social determinants of health, such as food insecurity, support services, or housing assistance? I'm seeing predominantly yeses here, which is understandable. A few no's, and then just one non-sure is up there, which is also understandable. All right, looks like the responses are coming in still just a little slow, so I'll give it another second or so.
So you all heard the responses from our great panelists. Both Valerie and Christine really highlighted the fact that a health system could probably come up with the staffing, but that core knowledge, expertise that's internal to CBOs and the ability to navigate and blend resources together to meet the needs of, as Stephen pointed out, the whole family, where we're trying to heal the whole house. That's not just one single referral, because as we all know, if a person that's suffering from food insecurity, generally that's not the only problem in the house. And so our ability to get in, find all the problems and develop a plan sounds like that is a significant value, but also sounds like from our panelists, something that they're having to educate the healthcare community about, because they don't inherently know all of the magic that occurs behind the curtain.
All right, well, I can move us to the next question, which we can have up now. So it's asking if you operate a care transitions program that specifically targets hospitalized patients that are eligible or may be eligible for one or more Medicaid waiver programs.
So it's important to note that the accountable care organization model, which is a risk-based contract model for hospitals and providers, but a lot of hospitals are the anchor for accountable care organizations or ACOs. When they're taking risks, when in their mind, what risk includes, it includes all Medicare expenses, generally Medicare Part A and Part B. What's not included in those risk formulas are usually Medicaid waiver program services. So when they look at how they can increase their ability to deliver shared savings or reduce the total spend for Medicare, Medicaid waiver is a great option, but they don't know how to always get people onto Medicaid waiver, which is again a core expertise of the Aging and Disability Network. Great. So now that we've talked about, or we've gotten your responses about social determinants of health and Medicaid waiver, I want to jump back with our panelists to dive a little deeper into your responses around social determinants of health. So social determinants of health have been pretty much universally accepted as a key contributor to health outcomes. And it sounds like each of you have an approach to address social determinants of health. Is that a standard process? And can you describe your process for screening and addressing social determinants of health identified for your population?
Actually back, but I'm out of Florida today.
All right. Yeah. All right.
So we can start with you, Christine. Can you let us know about your process for screening and addressing social determinants of health?
Sure. I think as Valerie pointed out, I'm going to try to keep this high level because the program is quite complex, but at a very high level, the ACO or our healthcare partners are required to do a comprehensive assessment. And as part of that comprehensive assessment, there are pieces of that do address or do look at the social determinants. Once the referral is made to the LTSS CP, we also do a very comprehensive assessment to dive a little bit deeper into the social determinants. At that point, once that assessment is complete, we work with the members to develop a comprehensive care plan. So that care plan is really a roadmap that's intended to empower members and lead members to goals, mutually exclusive goals. Once those goals are developed, and once we have sort of the roadmap of how we want to get there, that care plan goes back to the primary care provider and is signed off on. So essentially, I will say theoretically, the goal is really to have an inclusive care plan, one inclusive care plan. Honestly, I'm not sure that we're completely there yet. We still have a lot of fragmentation, I would say, across the BH, the medical, and the LTSS side. But the way that we sort of work around that is some of these higher risk members, we have care planning meetings and we have care team meetings. And these are our frequent flyers. These are the people that you're going to see in the emergency room. These are the people that are really, when we look at our claims data, are right at the top of the list in terms of expenditures. So we focus on some of these high-risk members, and we look at the care planning process to really sort of brainstorm how collectively we can work together to help these members meet their goals and help to drive down that cost of care. So once that care plan is signed off from the PCP, we work with the member to start working towards the goals. Once the goals are accomplished and the outcomes are achieved, and if there aren't any needs that are met, members do end up graduating from the program. And I think that's been one of the things that's been really encouraging for the navigators to see. That they didn't initially see in year one and even year two of the program. But as the program matures, that the work of the navigators is really paying off. So we're finding that those members that we're able to engage with, that we're able to connect with, that we're able to really empower, and educate around their goals of care, have been successful and have really made changes in their life that have all led to positive outcomes. So that's been really encouraging for our navigators to see that we have been able to graduate folks from the program. Again, not to say that they don't come back and they're not re-referred. There's always the chance that, you know, there is a lapse in some area of their lives. That is, I think, part of the beauty of this program as well, is that, you know, just because a member reaches their goals and completes the plan of care as it's initially developed, there's always an opportunity that maybe things didn't go well and we can work with them again. So we do have that flexibility within the program.
Great. Now I'll turn it over to Stephen and Valerie. Can you give us a description of how you all assess and implement social determinants of health? And we have a question in chat about what types of staff do the assessment and do they have particular expertise, or are they an RN, or if you could also highlight that for us.
So the comprehensive assessments that Christine referred to as being sort of the first part of the process are done largely by the ACOs themselves, although GLIS and probably Merrimack Valley also has some contracts to do the comprehensive assessments as well. Those are done by an RN. The internal LTSS social determinants of health assessments are done by our care coordinators, all of whom are trained community health workers, as it happens. And those focus more on the specific day-to-day issues. I would say that our focus really is on problem solving and on helping our members to identify a particular problem that they recognize is standing in the way of a clear goal, especially a health goal. I would absolutely endorse all that Christina said about how wonderful it is for the coordinators to see people achieving their goals and meeting the care plans. And we love to graduate folks, even though they may in fact be returning at some point in time when another problem confronts them. But I think what is really important to understand about care coordination and the social determinants of health is that what we don't do is sit down and create a life plan for somebody that has 47 pages and 62 things that they will need to do. It is really much more about getting people involved in their own problem solving. It is absolutely the realization of person-centered planning. It's person-centered implementation to a large extent. While many of our folks need supports and they need advocacy and they need connections, and we provide that, it really is about trying to impart that problem-solving attitude and capacity, which in many ways, I think, is rerouting how people think about how to get themselves out of situations. So it's really important, I think, to move many of our consumers from more of the survivor modality to much more of the normal or the living for the future modality. And that makes a big difference. Now, some of the social determinants of health are pretty scary. Some of them are really complex, and there's often a lot of work that needs to be done so that people can see a path forward. But I think that in large measure, what we do is we identify that path forward and do it in a way that makes it seem doable. So it's not, as I said, this complicated six-page map. It really is a very simple, we can do this, now let's try to do this, and then we will do this. So we also spend as much time as we can trying to identify how the social determinant of health needs are connected. It's often like, and I think about my grandmother and the embroidery she used to do and the threads that would tangle in the back. Often the social determinants of health are entangled like those embroidery threads, but she would magically know which one to pull so that it would all sort of come undone in the appropriate way. In the same way, affording folks the opportunity to learn how to solve problems allows them to move from one to the other, and it becomes much less overwhelming. So we take a partializing but comprehensive view toward how we can support folks to move through these challenges, And then we also try to incentivize and reward them because they see successes as quickly as possible.
Great. Sounds like there's a fair amount of health coaching that's incorporated into your process, which is excellent. I want to dive into the care transition component of your programs. You both mentioned that care transitions is a key component to the community partner program. So you, as persons that you're providing this management for, they get admitted to the hospital. How are you all notified that one of the persons you're managing has now been admitted?
Most of our hospitals are participating in one or another of the ADT, admissions, discharge, transfer electronic programs. Most of our hospitals participate in something called patient ping, and that actually pings us, as do the other ADT programs, lets us know when one of our members has arrived at the hospital or is leaving the hospital. So that makes care transitions enormously easier. In the old days, we did not have this. We needed to lurk around the hospital. Lurk is probably the wrong word. We needed to somehow be connected with folks at the hospital who could tell us who was coming in and out. So the electronic transmission really makes life so much easier, although there is an occasional hospital that does not participate fully in this, and there are some folks who somehow slip through the cracks, but by and large, we do know when someone has gone into the hospital or someone has left the hospital, and that makes it a lot simpler.
Great. So that admission, discharge, transfer data feed automatically gets uploaded into the hospital, or the hospital uploads that data, and then it filters out any client you're managing and sends an electronic notification to you when that person arrives.
Right.
That is excellent.
I just want to comment. I think what's interesting about that process that we've all learned and experienced, we're held accountable to follow up with those discharges within 3 days. So are our ACO partners, and they get notified the same way that we get notified. So when we first started this process, we were all rushing out upon the notification to try to connect with that consumer. This was a big part of the learning process and the collaboration to identify who should be the lead to first touch base with that consumer as they, or member as they were leaving the hospital. And again, it was a nice way. I don't know if it was nice at the time, but it was a way that we all learned to work together and collaborate because we both needed the same thing. We both had the same measurements to meet, but we really had to work together so that we could each meet them and ultimately connect with that consumer and get them what they need.
That is excellent. In many communities where they have an operational health information exchange, the health information exchange provides a similar service where they're able to provide this electronic notification. And someone in the chat asked about, is that being able to send and receive that electronic notification, does that violate HIPAA? And so, but usually these systems, there's an opt-in process where as part of the consent, the person consents to this information sharing, which then allows to transfer the information for you to receive that information. Is that correct?
That is correct. And we also have business agreements with all of our ACO partners, which allows that to happen.
Great. So that's another excellent point. Oftentimes we do encourage organizations that are working with healthcare providers to enter into a business associate agreement. And that business associate agreement allows the healthcare provider to send referrals to other organizations that they're working with in the management, similar to the hospital sending an order to a home health agency or an order to a MRI agency to do an X-ray or an image. They could send to any other organization that has that business associate agreement, which could include area agencies on aging, centers for independent living, other CBOs, or partnerships as we have with both of you. So that is excellent. So obviously because of COVID, things must have modified somewhat when the clients you're working with are admitted to the hospital. Do you have staff on site? Are you doing things in person, or how have you made modifications because of COVID?
So as I think has been the case with most services, there's been much more of a switch to telehealth. however, not entirely. So practicing all of the social distancing protocols. We have tried to conduct visits wherever possible. But again, I think there has been less of that because of COVID. There's also been a reluctance on the part of some of our consumers to have in-person visits as well. So we try to accommodate whatever it is that folks feel most comfortable around. So if it is a case where they are willing to have some sort of in-person contact, we have done that with the utmost social distancing protocols. Where they have preferred to do it not in person, we've either tried to do a Zoom or a Teams or a WhatsApp or whatever, or a phone call.
That is excellent. In some of the remaining time that we have left, I want to point out to the audience that both of these organizations that have entered into the partner program have also entered into a model that requires risk. And I know that a lot of organizations say that community-based organizations are not equipped to participate in risk-based contracts, but each of you have taken that step and began preparation to participate in a risk-based model. So I wanted to hear from each of you how you approach the concept of entering into a risk-based contract model and identifying those key metrics that you have to track in order to be successful with a risk-based contract model.
I'll start, but I'm hoping folks will join in on this comment. How do we prepare to do this? I'm guessing that we are somewhat pioneering in terms of mass health and understanding what these risks are. But what is critical is having data. We really need to know whether we're hitting the marks and how we're hitting the marks. And we need timely data. We are, I think, improving along those lines. But I think we've also recognized that we can't rely solely on getting data from other sources. We need to have ways to create our own as much as possible. We also need to have, I think, a very strong quality assurance, quality improvement process that allows us to look at dashboards very regularly, understand what those dashboards are telling us, be nimble enough to be able to move workflows around as they may need to in order to ensure that we are actually meeting those metrics. I think some of it is also understanding how we can translate what our different partners need to know in terms of what information we have and in terms of the information that we also need to know. So there's a lot of communication that has to go back and forth. But I really think if I had to sum it up, I would say it really is about having excellent data, knowing what that data is telling you, turning the data into information, and using that as a foundation for an ongoing QI process.
Great. And then from the Merrimack team?
Yeah, I would agree with everything Valerie said, and I would also add that it's been an interesting transition with staff in terms of our culture. At Elder Services, we've made a fairly robust investment in quality, and we actually have a dedicated resource because, as Valerie said, I think that in order to really prepare yourself for entering into these types of contracts, you have to have a system of record where you can collect and have data available to you. The other thing is that you need some sort of resource to help analyze that data. So you need to understand what your data is telling you, because that's going to be your driver for process improvement. It's one thing to collect data and look at data, but there's also, we have, as I mentioned before, there is a very prescriptive quality component to this program. So by contract, we have a very dedicated quality committee that meets monthly. We've developed dashboards very specific to the program. We're looking at performance, we're looking at productivity on a regular basis. We also have some analytics that have rolled out as of December of this year from Mass Health that have been very helpful in helping us understand where our CP benchmarks against the other CPs across the state. We also have a quality withhold that, you know, we don't meet our benchmarks, then we don't get that funding. So that's really important to prepare for if you're entering into this sort of contract. And I think a lot of the work we did early on with our staff when we were ramping up to get to go live with this program was to really educate our staff on process improvement. So I'm sure you've heard of the Plan, Do, Study Act and certain things, tools that are available related to quality improvement. We did a lot of education. We had a dedicated quality resource that's really been invaluable to this program. So I think, you know, you have to think about really dedicating resources to the quality component of the program, because it's an integral part of your success moving forward. Without that, I honestly think that you're going to struggle because we're now at I think a more robust point in the program where the conversations with the ACOs in the beginning were very process oriented. We had a lot to work out to even figure out how we were going to exchange information, how we were going to communicate with one another. So that was a big focus in the early phases of this program. We've now shifted to a very robust conversation, more around quality, and it's very much a data-driven conversation. So I would say to prepare for that, you need to have all those pieces in place.
That is excellent. I want to thank all of our panelists. You brought very great insight into the innovation that's occurring in Massachusetts and the way you approach implementation as well as risk. I also want to make sure that all of our participants look into the chat where we posted the link to the CMS Medicare data that highlights the current rate of COVID-19 spread, as well as admissions amongst the Medicare population. Pay particular attention to the percentage of dual eligibles and end-stage renal disease. That continues to be the population that has the predominant impact or disproportionate impact, I'd rather say, of COVID-19, both in incidence and as well as hospitalizations. Now I want to turn it over to Caroline Ryan to wrap up.
Okay, thank you so much, Tim. And to all of our speakers on the call today, thank you so much for sharing your experience with us and some of your insights on your work. We really appreciate it. And I'm just going to wrap up the call with a couple of last mentee questions. So we really do want these calls to be helpful and useful to you. And so we've got a couple of last polls just to kind of get your sense of how these calls are going, what kind of TA you'd like to see. So I think the first is, what steps are you going to take after what you have learned today to enhance your care transitions activities? So are there any nuggets of information that you may bring back to your organization, you know, talk more with colleagues about, or may look into after this call? And I don't think we'll be sharing the comments here, because we're wrapping up, but if you have some feedback, that would be very helpful. Helen, should we switch over to the next question?
Yeah, absolutely. So I can move us to the next question. If we go ahead and, well, actually these ones are being shared. So they are coming in now.
Oh,
the next questions, we did hide the results so that you guys can feel free to be anonymous, although they're really just going to be some Likert scale questions to get a sense of it, if you appreciated today's event, so that we can inform our future events and learn from the feedback that you provided. All right, so I will go ahead and just in the interest of time to move us along to this next question. All right. So this is just a Likert scale of strongly agree to strongly disagree of whether or not this event met your expectations. And just a reminder, results are hidden, so we appreciate any honesty. All right, and as these results are coming in, I'll keep an eye on the numbers. We are going to be posting I'll go ahead and keep this poll going, but if Jessica, if we want to share the slides again to show that last slide that we have to point people to where we are going to be sharing resources today, I want to make sure we share that. The mentee poll will still be active and you can keep it up in your other window and respond to the questions as I push through them. But we wanted to just flag that we're going to be posting the resources from today's event to the TA community site, and that link is there on the screen, and we can put it into the chat now as well. And then also, if you have any specific technical assistance needs, as Caroline mentioned earlier, definitely feel free to reach out to the ACL at care transitions at acl.hhs.gov. So we absolutely can answer direct questions or would take any feedback there as well. All right, so you'll see on the mentee side, I'm going to be pushing us forward. That's asking to the last question, which will be what types of TA or webinar topics would be helpful to assist you in implementing or expanding your care transitions program. And I can just leave this one up for a little bit to let people respond and insert in their thoughts on that. And I think we can go right ahead and close up if that works for you, Caroline.
Absolutely. Again, thank you everyone for joining the call today and for your participation in the chat on the mentee polls. This information is really helpful not only to share with your colleagues in terms of your experiences, but the TA information really helps us to tailor the information that we create and these peer hours that we put together to really meet your needs right now, sort of during the pandemic. So thank you so much for your feedback and for participating, and hope you have a great rest of the day. Thank you so much.